So who would like to go first today?
I can go anytime you like.
All right.
Okay, I'll start with this patient. So the time difference between these two is, as you see it there, September and now. This is a patient with esophageal cancer, and I'll show you this CT on which there are multifocal, multilobar, small peripheral opacities that have developed over time. And they are new except for one that I'll show you away from the pleural surface in the right lower lobe in a moment. But let me make this bigger and then scroll through and look at the morphology of these very small opacities, many of which are in the peripheral lungs. So for example, here and there are two good examples of them. And I'll take this one and make this one a MIP, a thin MIP. So I'll bring that down to there, maybe even smaller, and show them to you again. There are other structures that are also abnormal. I'll get to it in a moment. But I'm hoping everyone can appreciate that these opacities like this one represent very small tubular branching opacities. They are centrilobular, but the more one looks at these, the more you can appreciate that they are tubular and branching opacities in that location. So now let me go and show you some other findings. So previously, this opacity was identified in the more central right lower lobe. And let me make this big. And I'll scroll through that one, give you a feel for what that one looks like and where it's located. So in there, it's not enhancing, but you can tell it's close to a bronchovascular bundle. And right there, I hope you can appreciate, it's really subtle, right there, that there is clearly an intravascular component to it in relation to this segment of pulmonary artery. So now let me bring this one up again and show you what has happened to that one as well as some other ones. So let me scroll down and find this one, and you can see this one now is a lot bigger, but I hope you can appreciate that this one also is tubular and branching. And I'll just scroll back and forth to give you a feel for it. Now we have more vessels here, or more segments of vessels that contain that material and that are branching. And then as one looks some more, and particularly this one here I'll show you, elsewhere, you'll easily be able to appreciate that there is a vessel that goes there, and then at this point it's very distended with intraluminal material. So the findings here are very typical of intravascular metastases, both within segments of segmental arteries as well as lobular arteries. This is a case of esophageal cancer. I don't have pathologic proof, but I'm very certain that that's the diagnosis. And there are other ones like that, actually, in other places too.
The esophageal stent is a nice clue on the same images too, of where the source is.
Yeah.
And you have the pitfall of thinking this is related to aspiration, so it's important to make the observations you pointed out about the intravascular component.
Yeah. Just look at this one over here. I don't think I showed you that one. Look at that one. Yeah. Right here. You can just follow the vessel to its point where it no longer contains contrast, and then you can see the tubular nature. Yep. So this is the first one I've seen with esophageal cancer, I think. I've seen it with other kinds of tumors, but I'm pretty confident that's the diagnosis here. All right, let me show you some other interesting ones. I'll get to that one in a moment. This one is a quickie. It just so happens that, I think it was 2 weeks ago, that I showed that really interesting patient with the complete manubriosternal dissociation, where the manubrium was anterior to body of sternum completely with no associated fracture. This is a trauma patient that has a minor version of that same thing. So here he has a fracture, but you'll see that his manubrium is displaced slightly posterior to body of sternum. So there's the fracture there. There's a little hematoma in the mediastinum, but this is another partial dissociation between manubrium and body of sternum. And just by chance, I came across this case the other day too. So an interesting injury again, right there. All right. Onward. Okay. This one is just a curiosity. It's something that the likelihood of coming across this in chest imaging is pretty small. So I will show it to you because it's really quite interesting. So we have 2 radiographs here, and the time interval between the two, well, it doesn't really matter because there's a new finding on this one. So the context is that this patient has a lot of problems, but a primary problem is esophageal achalasia. She has pleural space disease. You can see by virtue of this that she received contrast medium evaluation to evaluate the achalasia, and she's had drainage of pleural fluid. But what caught my eye on this radiograph here is a new finding, and the new finding is this new object. So I'll mag that up. And I definitely didn't recognize this. It's easy to go by. It's partially obscured by the catheter, and it's kind of thing where you think maybe you don't know what that is, or just go by it entirely because it's on the skin or something. But this is a thing right there. So I will tell you that there was a suspicion based on a CT exam in which a small amount of contrast medium was seen, and I'll show that to you in a moment, in the pleural space, that the patient had a fistula between the dilated esophagus in the chest and the pleura. She did have a number of studies to evaluate that. Well, she had a contrast study, sorry, to evaluate that initially, and they did not see a leak from the esophagus, which is dilated, achalasia, and the pleural space on that. But because there was still a strong suspicion, she went on to endoscopy. On endoscopy, they did find a hole. The hole was plugged up with, as they described it, food at the time, but they did find the hole. So this is a device to close the hole. And I'll just mag that up again and bring it up here. And I'll show you what that looks like on the CT. So we'll go down there, and there is the object right there. And I've never seen that before. So I looked at the notes, of course, and that turns out to be something called an Ovesco clip that was used to close the perforation. So here is a little bit about the Ovesco clip. That's what it looks like when it's closed. And you can see it's got teeth. And that's what it looks like, and then it's closed. And I'll just blow this up so you can see what they do here. They put this thing over an endoscope, they go and they find the hole, then they use the forceps to basically grab both sides of the hole, they draw the tissue in, and then they allow this clip to basically clip right over it like that. And that's an image from the brochure showing the closure of that hole with the Ovesco clip. So just a curiosity, unlikely you ever see one, but if you do, now you'll know what that is. Like I learned, a Ovesco clip. They may be able to use it for bleeders, but I think this version was primarily created to close holes in the GI tract. Okay. And the last one I'm going to show you is very, very similar to a case I showed 2 weeks ago, also in an immunosuppressed patient. This patient has CLL, and the findings are almost identical: bilateral, large, new parenchymal opacities that looked like this, very impressive in size. Interestingly, there's interstitial edema in the lung around them, but just very large opacities. One here already is cavitating, so very consistent with opportunistic pneumonia. The one that I showed a couple of weeks ago turned out to be a nocardia, and I'm trying to remember the name, but it was something like Syriaci georgica, which was one that I had not heard of before. But this one turns out to be nocardia perseverans. So it is nocardia, and it is another species of nocardia. So here you can see that, just really quickly, that fairly recently they decided to give this particular species of nocardia a name. So we look up here, we see the usual nocardia, but this one here has now got a new name called perseverans. So this is, well, not that recent, but nocardia infection and nocardia perseverans in this particular instance, but otherwise very consistent with nocardia infection.
How was the diagnosis made of the specific organism?
I think they just, they cultured it from a CT-guided lung biopsy procedure. Okay. And then they typed it that way. So there was a CT-guided lung biopsy that was done of that one. And then they characterized it as that particular species of nocardia. Yeah. Alrighty, Jeff, those are my cases.
All right, more nocardia.
Hey Jeff, do you mind if I jump in? I gotta go soon. I got a meeting.
Go ahead.
Hey Seth, will you stay around where you can at least see one of the ones I want to show?
Yeah, sure.
Okay.
So this is a bad, nice case. Guy with esophageal cancer, bad, ugly stent, recently diagnosed, comes in a few days after this, or a few weeks after the stent was put in, and this is not related to the stent, but the first clue is that the stomach is filled with, he comes in with lots of bad things, like coughing up copious amounts of blood. You can see the stomach is distended, filled with lots of blood. The other nice thing about this study, if you ever want to see shock adrenals, you know, the adrenals are about as white as the renal cortices. And then you're looking for the bleeder. Well, there it is. So big bleeding vessel. Now, this was not a bronchial, so I spend time, but it's just for the sake of time. This was actually, the bronchioles came off at a different point on the prior study, and this little soft tissue here was new along the medial aspect of the aorta, along contiguous with the mass. The patient was never radiated. You can see the stent's really not in this location, so the concern was actual tumor ingrowth into the aorta. I don't know if that's true or not, but it kind of looks irregular. And then there's this just tumor eroding through the wall of the aorta, presumably, and then fistulizing with the esophagus. So that's a aortoesophageal fistula, and the patient unfortunately died about an hour after the exam. So just a massive, just a aortoesophageal fistula. This case, what was this case? Oh, yeah. Yeah. I don't know if I showed this case. I was looking through doing this research project on aorta. We have about 30 aortic sarcomas here. So anyways, this is not an aortic sarcoma. But I was looking up old cases of PEs, and this patient clearly has a large PE, and there's severe right heart strain. And the bad thing about this was that they saw something dangling in the aorta, but they called it mixing artifact. Now, I know this is before so we have this PM shift where we have people who aren't chest radiologists reading chest studies, which I am very much against. Nonetheless, you can see this serpiginous worm-like filling defect in the aorta, and the only way that that's going to happen is through your good old friend the PFO, which you can actually even visualize here, because of the mass. Now we all know that in normal people you do not get right to left flow usually from a PFO. It goes left to right, but because of the severe right heart strain, I mean very severe right heart strain, and this massive right atrium, that we actually get a reversal of flow, and we can actually see this contrast go from the right atrium through this PFO into the left atrium here. So this is basically a large massive pulmonary embolus becoming a systemic embolus from a large PFO. And not good that we many years ago called this mixing artifact, because the patient subsequently developed renal infarcts and lower leg ischemia and did not make it. So that was really bad. And there was a document.
Although I don't know what they would have done for it, right?
Yeah, I don't know, but they the patient had a document. Yeah, and they did document a PFO on echo that was done.
Yeah,
but you're right. I mean, what are you going to do? There's this huge thrombus in there. But it just was, bad form. This is a bad case. This is something I saw this and I was shocked because, well, I'll show you for various reasons. So here's a guy with a bad tumor. So he had a pneumonectomy. He had some sort of sarcoma. I would have to look it up. It wasn't a PA sarcoma. It was just some sort of lower extremity sarcoma. You can see that he has Mets. There are multiple Mets. He's got presumably, there's just Mets all over the place. But if we look at the heart, we see that there is this Met within the heart. Now, this is literally, let's see here. So this is a month later. And I don't even know how this guy actually walked into the hospital or got to the hospital. But yeah, I mean, I don't understand how this is compatible with existence. But he somehow walked into the hospital and got this exam and was sent to hospice after this. But you can see this just horrendous Met just now filling 90% of the RV, but he's still getting blood through because we still got a aortic contrast. But he does have a PFO. But although I don't think that much blood is going through a PFO, but he does have a PFO as well. Anyways, that's the most ridiculous growth of a sarcoma Met I've seen. I was really shocked when I saw that. And this was the case that I showed some of you guys. I figured I shared it with you guys for Jeff's poster. I might as well include it. So here's a patient who is a meth user. Needless to say, she is. Her history includes multiple horrible things, like 7 spontaneous abortions, in and out of jail multiple times, a lot of bad things. And we can see this absolutely massively dilated left ventricle. Additionally, even though her PA is not big in terms of compared to normal size, it is bigger than the aorta, and she does have known pulmonary hypertension. And then this is just the MRI. I won't spend a lot of time on it, but interestingly, let's see if I can get this to work some way, and we can see that the severely dilated left ventricle that is markedly hypokinetic. And what was interesting about this on the delayeds was that not only is there a little thrombus in there, but she does have this little area of infarct. So subendocardial infarct at the apex, and where that little thrombus is sitting, and she had normal cath. So, because I guess at some point she came in with a small troponin bump, and they did this, and presumably this was a vasospasm related infarct from methamphetamines, because they had no other. She was, doing meth all the time. So, anyways, dilated cardiomyopathy with pulmonary hypertension and, you know, a presumed vasospasm related infarct in a very heavy meth user. And the lungs are not normal as well. The airways are very abnormal. I wonder how much of this is vascular related. I would assume most of it's airway related, the mosaicism, given the severity of the airway injury in the areas where it's more hypoattenuated. But anyways, those are kind of quick shoot through my cases I've had the last week or so.
All right.
Thank you.
Yeah, one of the things I learned is about the meth-associated pulmonary hypertension is they do a lot worse than the idiopathic pulmonary hypertension.
Yes, they do real bad.
Yes. All right. So, Travis, you had a case to show Seth.
Yeah. I've got a few cases, a lot more cardiac stuff this week. This is an interesting one that just came into our congenital conference this week, and it's an interesting case, but it's also as much about nomenclature as anything else. So this is 3-week-old. This was done elsewhere, and the patient was referred in because they were trying to figure out, you know, the degree of left lung hypoplasia. That was the specific question, and also his left pulmonary artery branching pattern. And they tried to bronch him to see what his airway and, you know, what his anatomy was. And you can see that his extrathoracic trachea is normal caliber, and his intrathoracic trachea is tiny. It's 1 to 2 millimeters. So I'm guessing he probably has complete cartilaginous rings. That's at least my thought here, just given that he's got a lot of other abnormalities that you'll see. But when you quickly scroll through, you see there's a lot of volume loss, and there's on the left side and shift to the mediastinum. But what I think is interesting is that this is not necessarily a case of left lung hypoplasia. Rather, it's a case of left lung agenesis. As you can see, you know, this was described as just a hypoplastic left-sided bronchus, but when you look at this just looks like a trachea that goes into a right bronchus with some sort of normal right upper lobe branching, and then a right middle lobe here, and then the right lower lobe, which then herniates across into the left hemithorax.
Yes.
And so, you know, this gets into the question then of nomenclature. And I found this from a nice radiographics paper where I think this is correctly called pulmonary agenesis because you have absence of the lung parenchyma, bronchus, and pulmonary vasculature. There's absolutely nothing on that side, as opposed to either aplasia or hypoplasia where you have some sort of rudimentary bronchus, you know, and then some degree of lung development. Now, the one other question for everyone, and I know we've discussed this before and shown actual cases of horseshoe lung where you have fusion of the basal segments of the lower lobes. I mean, I like to call this a horseshoe lung just because it's right lung herniated across to the left, but I guess that's probably not the typical or the correct terminology for this case. Would you agree, or would you call it like agenesis with horseshoe? I
would just call it agenesis. And the cases we've seen with the horseshoe, we put horseshoe in quotes because there's still separate pleuras with we saw with some of the scimitars where you have somatic defects. And I know Dave talked about this with, really, it should be horseshoe sort of in quotes.
Yeah, and I saw one paper where they called this like crossed ectopia of the right lower lobe in the setting of left lung agenesis. I think it's probably just right lung herniating into the left hemithorax. Base.
Travis, can you show the vasculature? I agree there's no bronchus. I was just trying to, going so fast I couldn't quite follow.
Yeah, they're thick slices too, but you can see that's just the main pulmonary artery, and there's nothing on the left there.
You're right. And I think,
and there's no scimitar. You know, you brought that point up too. There's no anomalous venous drainage of this right lung, and the other clue is too, there's no left-sided pulmonary veins either. I mean, this is just complete agenesis of the left lung.
And the distinction between aplasia and agenesis is really academic.
Yeah, it's just there's because it's been called like the hypoplasia agenesis complex too, where it's more like a spectrum of findings. But I thought this was interesting because he had come in as billed as a hypoplasia of his left lung with just tracheal and narrowing and abnormal branching pattern. But clearly this just looks like a right lung, and you can see he's got multiple other abnormalities. He's got vertebral abnormalities. He is being worked up for syndromes now. So.
Did you say there were complete tracheal rings? I didn't.
I'm wondering because his trachea is like 1 to 2 millimeters here. I don't know. I mean, it's not extrinsic compression because there's no ring or sling.
Yeah, no, you're probably right.
So And they couldn't pass that with a bronchoscope. So, but I don't know, he's got other issues as well. Okay, then I've got a couple of cardiac cases. We've had a run on this diagnosis recently, and this is one of the better cases I've ever seen. This is a patient who's 62, and she actually, you'll see on the cines that she has a right-sided effusion and a small left effusion. She has large fibroids, had ascites as well, and was actually presumptively billed as just Meigs syndrome from ovarian, or she had a big uterine fibroid and maybe ovarian masses too, and as a result having ascites and right-sided effusion. But they did a pre-op echo before they did her hysterectomy and found that she had some degree of diastolic dysfunction. And so you'll see that her, just scrolling through the cines, that her function looks reasonable in her ventricles. She has preserved systolic function. She has big atria. And then you'll see on the delayed images here that this is one of the best examples that we've ever seen of diffuse subendocardial delayed enhancement. And not only is it involving the left ventricle, but it's also involving the right ventricle. Notice how there's complete nulling of the blood pool. And also you'll see that there's some thickening and enhancement of the interatrial septa. And so of course, this is like the most typically described pattern for cardiac amyloid. I don't think it's really much of a diagnostic dilemma, although it was a bit of a surprise when we said this, because that's not what they were thinking. But then they kind of put it all together and ended up doing a biopsy, a bone marrow biopsy, and found that she has a plasma cell myeloma. She had also developed some progressive renal failure in the acute setting. And so what was interesting, that they then sent her endometrium that they had already done for her hysterectomy to the Mayo Clinic, and they actually found that she had amyloid involvement in her, or it stained positive in her endometrium. I'm not sure how that really changes management, because you can make the diagnosis off of really any tissue where you find it. But I thought that was kind of interesting that they did that. So classic appearance of amyloid, and this is AL or light chain amyloid. And I think that one of the things that confused me for a while, but now we've seen more cases and there's more literature differentiating this, is distinguishing AL or light chain amyloid from ATTR or transthyretin amyloid. And there's some literature, cardiac literature, or that I'll show you a paper that shows that you can distinguish fairly reliably based on the enhancement patterns. But we always think about the typical delayed subendocardial enhancement. This is another older man, and you can see he has a little bit more hypertrophy of his left ventricle, reasonable systolic function, maybe a little depressed. But in his case, they were suspecting that he might have amyloid. And I'll show you his delayed imaging, and you'll see that it's, there's a little bit more involvement of the septum, and it's a little bit more diffuse. It's still involving predominantly subendocardium. But this is a better enhancement pattern when it's not just exclusively subendocardium. This is a crappy, yeah, there you can see there's a little bit more involvement mid-septum maybe, and even in the mid wall of the lateral wall as well. And so this was suspected to be the ATTR variant, which is what this turned out to be. He went to Stanford and had a biopsy that confirmed, and they did studies on it to confirm that it was ATTR. So these are the ones that typically have more hypertrophy. They're often, as you can see here, either wild type. I guess, like I was reading, 2 to 3% of African American families will have ATTR mutations, and so it's suspected to be an underdiagnosed cause of heart failure, especially in blacks that are older. But I included this paper from JCMR. This was one of the first ones a few years ago, just showing differences between AL and ATTR, and that usually you'll see more of a transmural pattern in these. I don't know, Seth, are you still on there? Or do you use this reliably as a distinction?
I call that the zebra stripe pattern.
Yeah.
I don't know why. I mean, it's just these this one's actually pronounced, but you have these cases where you have these, especially in the short axis, these intertwined lines of white and black from the delayed enhancement in some areas of spared myocardium. And sometimes they're really more, you get 4 or 5 different layers of it. And we do see those more in African Americans with ATTR. So Yeah. So I sometimes, even in my old reports at Maryland, I would, because we saw this quite frequently, say, you know, tiger or zebra stripe pattern may represent, you know, its amyloid may represent this subtype.
Yeah, most likely ATTR as opposed to AL.
Yeah.
Yeah. And then and one thing, you know, I think we emphasize this more. Charlie has emphasized this more than I ever did before. It's just the inversion recovery series, the TI Scout, where normally, because you know gadolinium shortens the T1 relaxation, that you'll see the blood pool should invert first and become black. But you see, like in this case, that the myocardium, because of the increased distribution of GAD in there, that it actually inverts before the blood pool does. And that's a fairly reliable indicator too. I don't find it always that helpful, but this is a good example of that.
Yeah, I find it to be very, very, very helpful. It definitely makes the diagnosis, but I've seen cases of subtle cases where early cases that's not as severe yet, so it doesn't happen. But if it's there, it's almost diagnostic.
Yeah. So this is a good example because you can see the myocardium's nulled between here and here, and then the blood pool nulls after that, and you can already see it's the myocardium. So those are two cases of pulmonary amyloid, and then this case came in last week that I'll show really quick. This is kind of interesting, and this is one where, you know, the let's see, I'll show you the CT. That this was a CT done at an outside hospital, and you can see that there's septal thickening, and it's mostly smooth. You know, maybe a little, you know, almost a little venous lakes there, but it's rather diffuse, and so the pulmonology team hadn't really seen this guy yet. There's a little consolidation at the right lung base, and they were withholding some history, and just has a lot of third spacing, and so thought maybe this was just going to be edema, third spacing, given all that he had, and then saw that, you know, 2 weeks later he had a chest radiograph, and he really looks identical. And this is, you know, they're trying to diurese him, and then they also, so then we expanded the differential and said, you know, deposition, something, you know, cancer, lymphangitic spread, etc. But then they threw in the history that the patient had a recent biopsy of their parotid gland, and it was all amyloid in their parotid gland. So wondering how much of this, if you guys agree, if you think a lot of this is just septal deposition of amyloid, so just a version of parenchymal deposition of amyloid in the setting of known amyloid in another organ.
I think it is. I mean, it's the last thing on the list of septal thickening, but it's, yeah. I mean, it's, I would be surprised if it wasn't. That's pretty impressive.
Yeah. I think David, yeah, David?
Heart function was okay in this person?
Yes, and actually I just looked today, they did an echo, and systolic and diastolic function were normal. I think they still have an MR scheduled, because that was the next thing we said was, or the next thing I told the pulm team, you know, could she have cardiac amyloid if she has known systemic amyloid? And so they haven't done the MR yet, but the echo was completely normal.
Can you scroll up to the mediastinal fat?
Sure. There's like she just had, there's just, you know, no normal fat. I mean, even look at the fatty tissues in her breasts just look like they're either full of fluid or it's all just deposition of amyloid elsewhere.
It's amyloid.
But it's interesting. I don't know what your experience has been, but how many of you have seen, at least who do the cardiac stuff, we used to see a lot of cardiac amyloid, and I have to say the ones with parenchymal involvement were, I can't think of one, and vice versa. Those with severe parenchymal involvement, I mean, I'm sure there are cases, I know there have to be cases, but yeah, it's interesting that the ones that have really bad parenchymal involvement, the hearts are usually normal, and the ones with really bad cardiac involvement, the lungs are usually normal. And
I think one thing, like if you were seeing a lot of the transthyretin, since that's usually that is isolated to the lung, right, or to the heart. Okay. I think, because it, you know, I think usually this is more light chain deposition in the heart, and maybe, yeah, I don't know why though you don't see it a lot in those cases. It's a good question. I mean, we've seen a couple, but I think this is, but this one we don't have any evidence that there's cardiac involvement yet. So,
Travis, did they determine the type of amyloid? Did this AL?
You know, I'll look it up while somebody else is presenting it, and it was an outside biopsy. I'll have to dig through the charts and see if they said it was. I'll look at the heme note because she's been referred there. So.
Very cool.
All right, Jeff, since we've only got 20 minutes left and you and David have to go.
All right.
I'll stop here.
Here. David, do you have cases?
Yeah, I've got a couple. So this woman had a normal chest radiograph at this point. She has a history of asthma, and her radiograph was looking pretty good then. But then 2 months later, you see that she's got this patchy upper lung predominant consolidation. She came in with a cough, and she even had a little bit of hemoptysis and has this radiograph, and she had CT around that same time, which shows lots of lung consolidation on both sides, very patchy. Looks most like infection. She's got pleural effusions accompanying this, and this got worse over a couple of days, and her radiograph got worse over a couple of days. So here's a few days later, you can see that this consolidation has not slowed down, and 2 days later, it's even denser like this. So she was bronched, and she had increasing return of blood on lavage, so they diagnosed pulmonary hemorrhage, and the cells were submitted for cytologic analysis, and she had 30% eosinophils. And by this time, she had a 6% blood eosinophilia as well. And so this was determined to be EGPA, but it was ANCA negative, which I guess is unusual with EGPA. So the insurance company denied the most favorable therapy for her for EGPA, but she's been managed successfully with other medications. And the diagnosis of was either going to be GPA or EGPA. And in view of her history of asthma, they've decided on EGPA. She also had, I think, a skin rash that was consistent. She did not have neuropathy, and she didn't have sinusitis. So this is EGPA, and I'm showing you this case partly because last week I showed the 20-year-old guy who was supposed to have EGPA. He had a diagnosis of EGPA, but he had findings of lymphadenopathy. We're now pursuing that case, and I will post that case if we get the diagnosis of mononucleosis, which I suspect we will. So the lymphadenopathy case last week that was supposed to be EGPA is probably a different disease, even though the guy does have EGPA. So this is pretty well documented EGPA, despite its being ANCA negative.
So David, it turns out about a third, if I remember, somewhere between a quarter and a third of EGPA patients don't have ANCA.
Okay, so
and it can be transient too. It can be positive at different times. And I think the drug I forget the name of the drug you're talking about, but it's an IL-5 inhibitor, I think, and it's been shown to be very effective.
Yes, but extremely expensive.
Yeah,
you know,
steroids do also. A lot of these patients with bad asthma are on steroids, which can blunt some of the eosinophilia. It's a hard diagnosis to make, but as soon as you said asthma and showed this, that was the first thing I thought about, because it kind of looks like an eosinophilic pneumonia or alveolar hemorrhage when they get lumped.
Yeah, I think the CT findings fit hemorrhage better than they do eosinophilic pneumonia.
Agreed.
In terms of, it's not being particularly peripheral or basal predominant. So, and she had both. Okay. So this is a case that I saw this morning, reading out the night resident. I don't know what the woman's admission was for, but she has EKG electrodes in place, so it was probably for chest pain. And she does have a little electronic device here. I'm not familiar with this. I've not seen anything like this before, but on lateral view, it's got a battery in it and stuff like that. People don't have MP3 players anymore. They just have cell phones, so I don't think that's what this is. And it's bigger than the implanted loop recorders that I've seen, but I don't know if anybody else has seen a loop recorder that looks like this, but I don't know whether she had some pre-existing cardiac condition that required monitoring. But I was entranced with her mediastinal mass here and her tracheal deviation. And I looked on the lateral view to see if this was a right aortic arch with aberrant subclavian, looking hoping for an impression on the back of the trachea, and maybe there's a tiny little impression here, but not enough to make me think of that. And okay, so let me just show you some more imaging on her. So she had some outside workup before she came to us, and indeed she does have a right aortic arch, but she also has a very nice and intact left aortic arch, which is smaller and lower, and she has a nice ring, and you can see that it is narrowing her trachea and it is dilating her esophagus above, and then her esophagus dilates below. She had an outside esophagram that shows this impression on the trachea about the same level that we were seeing before. And on lateral view, you can see that there's an impression both from behind and from in front on the esophagus. So I think she must have had esophageal symptoms to have warranted this. So let me go back to her CT scan. She had this very nice, this is done outside, 3D reconstruction of her aorta, and you can see the larger right aortic arch, and here from behind you can see the smaller left arch. So double aortic arch, and she's in her 50s, so you know it's probably symptomatic now because of our age and dilation of these vessels with age and stuff like that, but she's obviously survived a long time with this condition. And then I wanted to show you an infection because—
4 vessel sign, David? 4 vessel sign by any chance?
I'm sorry?
Does she perhaps have a 4 vessel sign, so-called?
She does, yeah. So
on the axials?
Yeah, yeah, so we relished that earlier. So she's got the very nice symmetry of her brachiocephalic vessels here in the neck. So here they are, 1, 2, 3, 4. Very nicely symmetric. Is that symmetric enough? That qualify?
Oh, I like it.
You like it, okay. So here's a young guy who has came in with a skin rash and ulcers in his mouth. So it was primarily a dermatologic presentation, but he's got this patchy low-grade lung consolidation. We just have 2 radiographs on him. Here's what he looked like the next day. I think I've got the next day up here. So things were a little bit worse the next day, but low-grade patchy lung consolidation, lots of skin findings, and mucositis. And I don't know if you ever heard of MERM before, MERMS, because that's what this guy has, M-I-R-M-S. Is that familiar to anyone? This was a new one for me.
Nope.
Okay, so this is mycoplasma infection with rash, that's the R, and mucositis. So diagnosis of mycoplasma was made by PCR, and this would present to a radiologist as pneumonia, but he was really admitted because of his, or he came to the emergency room because of his skin findings. And they came with a diagnosis from an outside place of Stevens-Johnson syndrome, because he had been, when he was first symptomatic, I think it was sore throat and appeared to be having an infection, he was put on Augmentin. And so then later on he came out with all his skin problems. So people thought, oh, this is the penicillin-induced, sloughing of skin that goes with Stevens-Johnson syndrome. But the lesions look very similar. The dermatologists were alert to this, and they said, yeah, it looks like Stevens-Johnson, but it also looks like MERMS. And then they made the diagnosis of mycoplasma infection. He got better on treatment for mycoplasma. He didn't have to be treated for Stevens-Johnson. So a new one for me, MERMS. So this is my only case of MERMS, guys.
And there was no bacterial superinfection? It was sufficient enough to cause him to be intubated?
Wow. Yeah, I don't know what the intubation was associated with lavage or something like that, whether there was any sort of investigation. I don't know about, I haven't looked up his clinical record to see how sick he was, and so I don't really know why they put the endotracheal tube at this point. I'll try to clarify that before I post the case. Okay.
Great.
All right.
So while Jeff is pulling his up, I looked up that last patient I showed with the pulmonary amyloid. They had a bone marrow biopsy and a fat pad biopsy, both positive for amyloid, no surprise. And it is light chain. There was a clonal population, so it's a presumptive diagnosis of myeloma now. And also, they said that the patient has an elevated BNP and on their most recent EKG, a low voltage. So they're more inclined to get the MR now because they suspect it might be early amyloid in the heart.
Cool.
So that might turn out to be interstitial edema rather than parenchymal amyloid after all, right?
Oh, but it was there on multiple studies and hadn't changed. So.
Well, could be both.
Yeah.
All right. I'll show this quick. So this is a 4-year-old, and this was just given to me yesterday. I don't know the history, but presumably he had some shortness of breath or some sort of symptoms like that because this was his first presentation. And I'll show the echo, but this is just a really nice example of an R kappa. And so the right coronary artery you can see comes off the main pulmonary artery right there and skirts by the aorta, but doesn't seem to touch it, and then goes down normally. And you can see he's got his other coronaries are pretty big. The LAD is quite large, so presumably that's what's keeping everything happy. And then here on the echocardiogram, what you can, if I can get it to run, let's try this one here. Still loading up. You can see that the direction of, so here's the you can see that there it goes, but you can see the direction of flow is coming into the pulmonary arteries, going in the same direction here. So it's showing the shunt away from the heart. But I'll send this on, and here's just a reformat. Oops, turn this off here, but because this is rotational. So there's aorta, here's pulmonary artery, and then this thing is coming right up there. And so that's an arc. Yeah.
And the big left coronary artery is typical too because it's increased flow through that then reverses back into the RCA.
Right.
So, yeah, it's nice.
Right. So this is a case, interesting case. We got some serial CT images, and so this is a how old did I write down? 54-year-old female. So this is the first scan, and was done for some vague symptoms. And you can see there's, as I scroll through, you'll see these poorly defined nodules. Some are a little bit more solid, but they seem a lot of them to be associated with the airways. So, you know, at the time, thought maybe could this be infection or something? The other thing, of course, with the airway centricity, you know, sort of this bubbly lesions, would you wonder about an adenocarcinoma? So a short-term follow-up was done for whatever reason, and you can see that these have gotten larger over time. There's this pretty big one down here in the right lower lobe. And eventually these were biopsied, and instead of adenocarcinoma, this was all malt lymphoma. And so this is one of the more extensive cases of primary pulmonary lymphoma I've seen with the malt type. I've seen ones with solitary nodules. I've seen them with, you know, a handful, but this one is quite extensive. So the presumption is all these ground glass nodules are actually areas of extranodal marginal zone lymphoma and not anything else. And the distribution along the airways is quite typical when you see this along the lymphatics of the airways. And then there was just another CT done a few months later, and you can see this is just kind of continuing to slowly get worse. And these can be hard to treat because they're often very indolent, but if they start acting up, they will consider using some chemotherapy. But they're generally indolent or at least low-grade lymphoma, so a malt lymphoma. This is just kind of a cool case because it's not something you typically see. This is a 48-year-old male who presented with some chest symptoms, had a radiograph. Unfortunately, it wasn't sent to us. This was an outside study, but led to the CT, and you can see there's this extremely large hypervascular mediastinal mass. And this came to my attention from the surgeon who was wondering how to take this thing out. This was biopsied and is a primitive neuroectodermal tumor, PNET, which we usually think of in kids like Ewing sarcoma type tumors. I don't recall ever seeing one in an adult in the mediastinum, but you can see, although it is hypervascular, it seems to be just displacing the arch vessels and just kind of sits on top of the aorta. But you can see there's a lot of these hypertrophied vessels around it, presumably coming off the intercostals and bronchial arteries. So they may consider doing embolization pre-op, and then I think the thought is to do a clamshell thoracotomy for the best chance of resecting these, because apparently, according to the oncologist, these things do not respond very well to chemotherapy or radiation. So surgery is really the best choice for this patient. And it seems to be just isolated to the mediastinum. There's no other extrathoracic, but quite a bunch of mass effect on the trachea, the esophagus, and everything else in its way. Yeah.
It doesn't have any sharp edges. That's going to be hard to get that out.
Well, I don't know, because it seems to be a plane right here. You can see it sort of, you may be right. It seems to sort of indent, the vessels seem to indent on it, but you can see there looks like there's a little tissue plane with the left common carotid and even the brachiocephalic. So it may have a capsule around it, but with all these feeders, it may be kind of a mess. So I don't know the definitive plan. And last, it seems to be a cardiac day. This was a cool case that was also shared with me by one of my colleagues. This is a 53-year-old woman who has known congenital rubella syndrome and has had a pulmonic valve replacement. And she presented for imaging because she has some other issues. But you can see she's got these branch pulmonary stenoses with these aneurysms. And that's a known complication of congenital rubella, is pulmonary stenosis and branch pulmonary stenosis. But she's got a lot of aortic disease as well. You can see she's got a really thickened aortic valve. She's got atherosclerosis and her aorta's dilated. This is a cardiac portion, so I don't have the whole thing. But then you can see as we go down inferiorly, she's got this huge aneurysm. So this was to evaluate all of that as well. So, and presumably all related to congenital rubella, but it's just a nice example of branch pulmonary stenosis.
I don't remember hearing about aortic disease in rubella syndrome.
I looked into that and I couldn't find anything, at least in the brief reviews I saw. So I'm not sure if that's really why she has that, but she's only 53, so atherosclerosis would not be really high on my list. And then here's a case that I think one of you showed. This was a patient, an older patient who presented with chest and abdominal pain and was transferred here. This is all the outside study, but you can see there's a large hiatal hernia with intrathoracic stomach, but then there is extraluminal gas in the mediastinum there. So it looks like some perforation. And the CT, unfortunately, doesn't do as much justice, but we have a beautiful fluoroscopic study here. And let me show the image right there. You can, so here's the intrathoracic, so dilated esophagus, and then there's your ulcer that perforated. This was a culprit ulcer with a little bit of contrast coming out right there. So not something we used to look for years ago on upper GIs with these ulcer diseases, but this is one that is, even though it's a stomach, it's in the chest, but just a nice case of that. So they repaired this with a patch. This case did not fistulize anywhere, so it was just in the mediastinum, but an interest.
Is there pneumomediastinum throughout? Because it's interesting, because you point out, yeah, it is in the chest, but you don't see a lot of.
No, you don't. It's really
interesting. It makes you wonder, even though it's in the chest, is it truly, in the mediastinum, or is that air still
pneumoperitoneum?
Yeah.
Yeah, that's a good point.
Huh.
Well, there should still be an intact. What's the name of the fascia, that transverse salus fascia? If you have a hernia and you have a hernia sac, then the air is contained within the sac and therefore doesn't communicate with the mediastinum, right? Because the hernia sac has peritoneal covering of, is it called transverse salus fascia? And if that's intact, then the air will be confined to the sac.
That's a good point. And that's what it looks like. It looks like it is contained right in here because you really don't see it.
Yeah, it's as if the peritoneum comes up and attaches to the esophagus. And if the esophagus moves higher up into the chest with the stomach, it drags that sort of tent-like, as if the esophagus is a tent pole. It drags that peritoneal reflection with it. So
yeah, that's why it literally is a sac. Mm-hmm.
Mm.
Yep.
Cool. Well,
so the salus fascia is the sac, and it's intact. I think it's called the transverse salus fascia.
Excellent.
Jeff, can I show one more as a quick management question?
Sure.
It's pretty quick nodule. It won't take that long. I'm just curious what people think.
So Jeff, that guy would have abdominal pain from his gastric disease, even though his stomach was up in his chest.
Right. Yeah, he did have abdominal and chest pain. So, you know, the epigastric area.
Curious. So this is a lung cancer screener from our VA population. You can see he's smoked a little bit at least. This nodule in 2017, it was followed every 6 months. It was slowly growing. Then this is June of 2018, and you can see why we're reluctant to biopsy. I'm just given his degree of emphysema. And so they finally did a PET, and the PET shows that it continues to grow, but there's absolutely no uptake in this thing. And it's now, you know, over the course of 17 or 18 months has more than doubled in volume, but there's no uptake in it. And when you look at it, you know, it's, if I zoom in here, you'll see, you know, it's too small to say if there's really macroscopic fat in it or not. But I guess one question is, have you guys seen like intrapulmonary lymph nodes that are this lobulated, or could this be just some sort of smoldering granuloma, or what would you do about it at this point? Take it out?
Yeah, I was going to say that because, I mean, I've never seen a lymph node that was lobulated, and it's kind of grow. I mean, I've seen lymph nodes wax and wane, but I've never seen them just progressively grow without a good explanation. I mean, I guess the issue with all these is at some point you have to decide what's your threshold to do something, because we just keep watching it. Do you give, or do you just, it's so peripheral, you could probably wedge it out pretty easily. Give him a little.
Yeah, I think he's got vascular disease, horrible lungs. I mean, I think they might just do SBRT without a diagnosis, but
yeah.
But you would expect that this was a screener. It should be high. So in the VA, are they screening patients who aren't lobectomy candidates?
Yes.
Wow.
Because some of these patients will get SBRT if you find a stage 1.
Okay.
Yeah, I think one should definitely give points to the PET being negative. I think that is informative in terms of what this might be, a less concerning lesion, even if it's growing a bit.
Yeah, because there's absolutely nothing in that. So it's bizarre.
Yeah, if you took this thing even just as it is now and ignore the growth and just looked at the PET and used the Herder equation, the Herder predictive rule, HERDER, and you plug that in, even if you plugged in emphysema, the PET negativity will carry a lot of weight, and you'll probably get a really low number for the possibility of a lung cancer. But it is interesting that it is getting a bit bigger, but it's got smooth margins and PET negative.
We had a similar case, I was just reminded, we had a similar case here just recently that was taken out, ended up being a hamartoma, but it was growing, but FDG, really not FDG avid.
Yeah, and certainly we've had our share of hamartomas that grow. This just seemed to be pretty rapid growth.
It's also it's not a very good shape for hamartoma, though. Hamartomas are usually nice and spherical, and this one is not. But I think the point is that even if this is a low-grade malignancy, it's probably not going to determine his lifespan, because he's got so much emphysema and only 70 years old. This is not going to kill him. I think you could just leave it alone.
Yeah, even if it's a carcinoid that's growing a little bit, it may not hurt him whatsoever.
Yeah. So, okay. Well, I just thought I'd throw that out there. I think we're all kind of similar.
I think that's why
just more conservative.
In the recommendation for the USPSTF recommendations for lung cancer screening, that's that they have to be able and willing to undergo definitive resection, because then you don't get into these situations.
Yeah, that's not a point that's been brought up at the VA before. We screen, we have over 1,200 patients in our screening population now, but I didn't realize that was one of the requirements. At least in the US.
I don't know about the VA, but in the private sector, insurance company, Medicare, that's one of the part of the shared decision making. All right,
cool.
Thank you very much.
Thanks for your input.
Talk to you next time.